Welcome back, everybody. This is the part of the meeting where you have a very extensive and experienced panel from a number of different organisations who are going to answer every question you've ever had about an ACO, or not, and I'm sure they will. What we're going to do is Jane Lovian from the LMC, who you'll all know very well indeed, has got the questions that you've already submitted in advance, and she is going to put those to the panel on your behalf.
Can I just very quickly ask, because some of you may not know, everybody who's up here, if the panel could just very quickly say who they are.
Paul Dunn, Finance Director, Northumbria Healthcare.
Jeremy Rushmer, Medical Director, Northumbria Healthcare.
Vanessa Bainbridge, Chief Operating Officer, but some of you will also know me as the Director of Adult Social Care in Northumbria.
Sam Alistair, Roberts, half an hour ago.
Bijou Bartoli, Exec Director of Performance and Governance at Northumbria.
John Lawler, Chief Executive of Northumberland Town and Way Trust.
Deputy Chief Exec at the Council and System Transformation Support at the CCG.
Stephen Mason, Accountable Officer at the CCG and also Chief Exec at the Local Authority.
I'm Janet Guy, the Chair, and I'm not part of the panel.
And Siobhan.
Siobhan Brown, Transformation Director at the CCG.
Thank you very much. Now, the first section is on GP contracts and income. Perhaps Alistair, how much will the ACO contract be worth to primary care providers? What is actually on the table, and does anyone know this yet?
So the answer is about £4 million, which is what the current CCG spends in what we used to call local enhanced services, which would be transferred through to the ACO, and so that would be where we would start at. But clearly with any ACO, the successful ACOs tend to change the funding streams around primary care, community services, and bits around mental health as well, because we know that actually investing in those areas does tend to reduce the spend in the whole system.
When we constructed the business case that went in December, there was a 3-year plan to get down cost and investing in services such as mental health to reduce the costs across the system will be key. But there is also we're all going to have to work differently to make the system sustainable, because it is not sustainable based upon the current financial projections that we have across the system.
Next question. As GPs, up to 15 to 20% of income comes from enhanced services, and I assume that these will be threatened by an organisation which will start off financially strapped and will experience tightening of its financial position. We cannot guarantee this income, and if it goes, the teetering pillar that is general practice will likely teeter further.
First thing is that whichever way we look, be it an ACO or actually continuing with the purchase of provider split, the finances are as they are. So there is still a risk that the CCG enhanced services that are there would be at risk. But I think what we're looking at is that basically bringing the system back into balance is a key priority. Under an ACO, that doesn't change, but we would really look at what are the good services that are out there that are being done by primary care, and I think the evaluations at present is that those are really good value, they deliver for patients, they deliver for the system, and so there would be no intent on changing those. Primary care, along with the trust, would be at the moment the two main providers around the ACO, with others joining in due course, and I think they would then have very strong clinical and operational voices around how the ACO functions. So actually primary care would be actually around the table deciding how it spends money. Now we've got to be very careful about conflicts of interest there, but clearly you wouldn't want to rock primary care, because actually we know that wobbles in primary care actually increase costs in secondary care. So if you send people through to A&E, there's a general gearing of a 1% change in primary care flow is about a 10% change in secondary care flow. So we've got to be common sense about this.
For me, the ACO is about bringing us all together to work differently together. And I think, as Alistair says, the most important thing is a single focus in terms of the financial strategy and how we deliver care at the lowest cost and the best value for the patient. And the current system, the way it's constructed with the barrier between secondary, primary care, etc., doesn't work. And I think we're seeing that now. We're seeing a groaning worsening of finances, and unless we all change together, we won't make the system financially sustainable.
Could I just ask John Lawler just to comment about NCW's status as a partner in this?
Yeah, happy to do so. We've been involved with the discussions more or less since day one, and the issue really for the organisation is just understanding what the scale of the financial risk is that we'll be taking on. So I've discussed with Beju very recently that we'll definitely want to be, as a minimum, a strategic partner, which means that you would have a seat round the table at the ACO board, but that you wouldn't necessarily, unless you fully accept all the risk that goes with it, have a voting seat around the table. So the conversations we've had to date is that, subject to seeing a bit more clarity, as you will all want to see, around exactly how it's going to work in 2017-18, we will either join from day one or probably more likely be a strategic partner and join fully on the 1st of April 18.
I would have said no. I think we've tried from the very start that the independent practitioner status is preserved within this. There is no model of employing GPs unless GPs voluntarily choose a different form. The only staff that would be directly affected in terms of their employment would be the CCG staff. And I suppose those are pretty key for me. And I also think if you look at the people around this table, all of them have got a long-term track record in public sector working, be it for the local authority or the trusts. And this is not people who've just descended for a year. They've been here for years and years. I think if they were looking at the private sector, they would all have been in the private sector for years. And I think there is a massive public sector ethos in everybody on this table and indeed in the room, which I think we've got to really bear in mind. I think the other thing is that the fact that your core contracts remain outside the ACO has been there, because that was one of the red lines that primary care had. And so that does preserve an awful lot of your worries about the autonomy there that is actually written into how you would function, because your core contract doesn't lie within the ACO. So even if everything changed, you're still independent practitioners and you've still got your contract.
Just to echo what Alistair said, there's never been a master plan around salaried GPs. It's always been very much, if that's what you want, that's fine. If it's not, that's also fine. I think this is about, you will have heard colleagues say this already, about us collectively understanding and owning the position we find ourselves in, and actually if it's our problem, how can we fix our problem together? And that is a genuine will and desire to do that, and it's really for us now, I think, to decide how that's possible to deliver. Thank you.
Just about the overall budget which the ACO is going to have to play with. I mean, we know about the primary care bit, but for me it's quite important that the overall budget that you've been promised or that you're taking forward is going to be similar or equal to the budget that you've got now to provide all the services which you are providing. Do you actually have any assurances that that will be the case, or is there actually going to be a budget cut overall?
We are looking to take on the full CG allocation, albeit there will be some excluded services from the amount of money that will pass down to the ACO. And indeed, in the business case that we submitted in December, there was an ask of the centre that we have some transitional support over the 3 years in which we're going to have to deliver sustainability of the system. Now, that is and will be centre of the final business that goes into both NHS Improvement and NHS England, and it'll be fundamental to helping support the system over what will be a dramatic period of change in the next 3 years.
If I could just add to that, I think it's important to say that when we look at the budget, one of the dilemmas we've got is the system is operating beyond the budget. So one of the difficulties we have is we actually have to reduce expenditure in line with the budget, because we can't carry on with the current level of overcommitment, and obviously it's felt that the ACO will enable the system to get back into balance.
Just to amplify that comment from Stephen, the current outline business case envisages a 50 million reduction in cost across the system over 3 years, but you've got to add on top of that the provider cost reduction requirements as well. So I know for our organisation it's roughly 50 million attributable to Northumberland over 3 years, and I'm sure John's got a similar challenging number for his services as well. So there is going to have to be a big focus on reducing cost over the coming 3 years.
even before you get into the overcommitment across Northumberland that we've talked about, each year providers have to find a 2% minimum cash releasing efficiency saving. So the way I describe it to staff in our organisation is each year we have to deliver £6 million of services for free that we got paid for this year. And so that's sort of the minimum, if you like. So over the next 3 years, there'll be about £18 million of savings that NTW will have to find before you factor in all the other unfunded cost pressures.
Start off with one for Steve, please. What is the alternative option to an ACO? There are other options that have been put forward. Why is this the one that we are following?
Obviously, we could carry on as we are, but I think the evidence would indicate that we've not been very successful in terms of the current organisational structure. There is a significant imbalance within the system. Obviously, through the ACO, it is felt that it would actually encourage greater cooperation across the system, and obviously would move away from the tariff-based system, which I think has generally put CCGs in a weak position nationally. So it would encourage more integrated working. Of course, you could try and replicate that in another system, but it is felt that it's the best way forward. And perhaps more importantly, it might give us access to national transitional funding that wouldn't be available if we carried on under the existing arrangements.
We, Northumberland, benefited from being part of the PACS Vanguard, so we've been able to use that badge as well in terms of some of the transitional funding that Stephen's talking about, using that as an opportunity to say we can do things differently. I think the status quo would be staying on PBR, which I think we would all accept is not the place where we want to go. We want to do something different, because it needs to be something significant in order to make the change that we need to see.
And I think one just for Alistair, why not an MCP?
I suppose one of the things that I think, my observation is that the money spent largely in secondary care. We know that the majority of the NHS budget, we've got 8.5% currently spent of the NHS is spent on primary care. There's similar amounts on community. If you don't put what the people who're spending the money in the room so that we're all on the same team, I do think the MCPs are going to be sniping around trying to get the acute trusts involved in what they're doing, as opposed to actually having them all being in the same fold at the start. And I think that the levers that the MCPs will have are actually going to be fairly similar to the levers that the commissioners have, because actually an MCP doesn't change what happens with PBR. And I don't think PBR is necessarily a complete evil, but it does mean that people aren't always on the same team, and an MCP isn't about parking PBR, and therefore it doesn't free people up to have the clinical discussions that I think will make the biggest difference.
North Tyneside will not be working as an ACO, so how will Northumbria work as an ACO for part of its organisation and PBR for the other?
So I think that's a really good question, and it's one that I think internally we've struggled with slightly, and it's one that we're going to have to explain to the not to the commissioners, to the regulators, both NHSI and NHSE. We will have to set up two systems in terms of an accounting mechanism, because North Tyneside will still be on PBR, whereas Northumberland will be on a capitated budget. I think there is an opportunity here, though, for North Tyneside to learn from Northumberland and what happens in Northumberland. So many of you will remember that there was a process that was being undertaken in North Tyneside to look to move to an ACO as well, and for various reasons that was paused. I think there is a view in North Tyneside that, well, let's just see what happens in Northumberland. Let's learn from what works well, what could be improved, and that we would perhaps think about moving in that same direction at a later date. So I think there is an opportunity here. I think as a trust, we just need to work out a mechanism as to how we separate the two out. We do that now in terms of Northumberland and North Tyneside patients. They're treated in the same way, but from an accounting mechanism, that difference already exists. So I think I'd like to see it as an opportunity for actually North Tyneside to potentially benefit from what we see happening in Northumberland.
What are the risks to primary care in an ACO, and how are they going to be mitigated? How can we ensure a fair weighting and representation of primary care on the ACO board? And what is the level of risk and responsibility, including financial, that primary care will be expected to take? And
Yeah, certainly. I mean, obviously you've raised a number of issues there, and I think in many ways the argument would be if primary care is fully involved, that's the way you would mitigate the risk. So, and I think in terms of the overall level of risk, obviously it will be limited in terms of, obviously, you know, the majority of financial risk would transfer to the ACO, which would sit with Northumbria Healthcare. So in many ways it does change the risk profile within the system and moves risk from the current CCG to Northumbria Healthcare. So, but I do think obviously your full involvement would minimise any potential risk to primary care.
So I'd probably turn the question a little bit on its head and say, what are the risks to not doing it for primary care? And I think that probably a number of you are already feeling some of that now in terms of the system that we find ourselves in and the pressures under which primary care work, hospital staff work, and the services that we can deliver for our patients. And I think we need to see it as what would happen if we didn't do this rather than just what are the risks, because I think that kind of focuses the mind. We've thought a lot internally with our board around what are the alternatives, which I know we've posed the question here already, and instead of the question being what's the risk to the organisation, it's the risk to the organisation and the local population of not doing this. I think we've always said from the very early discussions around the ACO that primary care had to be a part of it. This wouldn't work if you weren't at the table with the rest of us, because, as I said at the beginning, this is a collective venture. It's about showing system leadership. It's about being collectively responsible for the outputs and outcomes of patients in Northumberland.
Not so much to do with the risk to general practice per se, but just in terms of the what's going on the other parts of the Northumberland Tyne and Wear footprint. Basically, in every part of the NHS, and certainly in every part of Northumberland Tyne and Wear, there are different discussions happening that are all saying the same thing, which is what's the best way of trying to integrate physical health, mental health, social care around the needs of individuals and families and communities. So what I would probably say is that what's being discussed in Newcastle and Gateshead is very similar but slightly different than what's being discussed here. Similarly in Sunderland, where there is a multi-specialty provider being proposed, where they're talking about having a community provider for all of those services. Similarly in South Tyneside, where work's being done based upon the care pathways from Canterbury in New Zealand. I would say if you were to sort of write it all down and say, so what's the similarities and what's the difference, there's probably close to 90% similarities between what's happening in each of the localities. So that's not to say that, that there aren't differences. It's not to say that ACO is the only show in town, but the alternatives are very similar in each of the localities that we're working into.
how long will the ACO be allowed to function before it's being judged as a success or failure? Now, this can be taken financially, but I think a lot of our primary care colleagues want to know what actually will make a difference and how will that be judged.
So I think it's absolutely clear that there's a financial envelope to all of this. But for me, as a clinician who lives and works within Northumberland, I think that what we really will live and die on is if we can get a properly integrated system that works for the clinicians. So for me, what this needs to be all about is us working differently together. And I think the real opportunity here is to try and create a system that isn't led by the flows of money, but is led by the clinicians in order to deliver care for the patient. So I think there need to be some very, very clear outcomes in terms of what we deliver for our patients and the staff experience that we feel as well as the financial outcomes.
Well, on the financial side, I think there's an expectation that the system will get back into balance within a 3-year period. Now, I think in fairness, that expectation will be whether or not the ACO goes ahead, but it is felt that obviously the ACO would help the system. But I think there is a very strong drive to say that there's a 3-year time horizon.
How will disputes be resolved when there are only 2 voting members on the ACO board? And I think that we can say that all that detail is still in discussion, and we are all part. We are now, as primary care has signed up to this, to the ACO, we are party to that discussion. We are currently providing information and proving our worth to a vast number of organisations. How will the ACO ensure to avoid bureaucracy and that it does not add to this already heavy burden that detracts from direct patient care?
Okay, I think it's a really good point, and it's one that's close to mine and Bijou's heart, because we just were sitting in a room on Friday with NHSI, NHS England and CQC. So when we initially put the outline business case in, we had a meeting on the 23rd of January, 11th of January, and we were asked, what locally are you going to do differently? But to be fair to NHSI and NHS England, at the same meeting, they said, actually, what are we going to do differently? We need to have some internal thoughts about how we reduce duplication, how we have one voice to communicate with the ACO, with what will the relationship be with the Strategic Commissioner. So they've done some work internally, and they kicked off a workshop last Friday. CQC were also invited. I think it's fair to say that actually the CQC discussion is probably clearer than the NHSI and NHS England, because the changes in registration will probably be minimal, if not any changes at all. And I think CQC agreed with that. So they were quite happy at the end of that workshop. But there are further discussions to be had with NHSI and NHS England, and that will be happening over the next weeks and probably months to come as well. But Bijou may want to add to that.
There is an acceptance of the duplication that currently exists in the system, which I think might sound very simple, but is a huge step forward. There was a suggestion that was put forward that NHSE may be able to get its assurance from NHSI. And again, that would be a big step forward, because it means we would only be submitting information once. The data that they both use currently is the same. It just has to get posted twice currently. So I think there is a real potential to streamline services, and that in itself will create a number of efficiencies.
How much freedom is the ACO going to have to make its own decisions about the future provision of care?
I guess there's a few constraints we'll have to work under, and Stephen's articulated one of those with regard to the expectation that the system gets back into financial balance relatively quickly, and expectation at least in 3 years. I think if we can demonstrate that we're making significant progress on that, and picking up the point that was made by Jeremy, also demonstrate that we've got absolute clarity on what the key priorities are for local patients, local populations, and that we're actually moving in the right direction on those things. I think the how will be down to us. So I think there'll be certain whats that we'll have to be able to demonstrate progress on. But the whole point of an ACO is to make sure that the various different sort of barriers and organisational structures that potentially get in the way of the way that we do things together. If we can meet a few high-level objectives that the powers that be will expect of us, I think there's probably going to be much more flexibility than we've been used to over the last several years. That would be my feeling. Sitting in an organisation that feels that, despite us supposedly doing most things pretty well, spends a huge amount of time reporting upwards and telling people what they should already know. So I think from a reporting point of view, as Bijou's already said, and Vanessa has, that should get easier. But I think much more importantly, I think we should be able to say, why have we always done it like that? And because in some time in 1968, when the first GP contract of post NHS reforms in the 1940s came out, if there's reasons why we want to do that differently and people are supportive of that, then we should be able to do it. Just as in the world of mental health, there's been a whole range of things that have grown up over many years that we're trying to change, that prevent us from having to do things in what are an incredibly bureaucratic way at the moment. And I know cause frustrations for GP colleagues, and I'm sure we'll get into some of that if there's time.
I think it's very easy to say we just contract for different things, but actually we all know that the thing that makes the difference for primary care and indeed for secondary care is the clinical discussions, it's the pathways, it's all of those things that actually really make change. And I just think the ACO gives us a freedom to do that in a much easier way, because you actually do the right thing for the patient. And we actually start looking at the true costs, because PBR doesn't tell us what the costs are of the system. It allows a much more intelligent way of actually looking at where does the money need to go to support people, where do we need to do that. And I think the one thing that we've not mentioned yet, which is probably paramount, is workforce. If we don't actually do a system-wide thinking about what do we do about workforce, we've got pressures in primary care, we've got pressures in mental health, we've got some specialties with pressures as well. We can all start robbing Peter to pay Paul, and that will run out within a matter of a year or two. So actually tackling those sort of issues, which will fundamentally make a massive difference for us all, actually doing that once, doing that at scale, using where we can to support individual practices and to support actually patients, I think that's where the richness will really come.
I only want to work for a clinically led system. That's what I want to achieve. I think that's where all the gains are. And I think if we can convince people that we're doing it and delivering better for our patients, I think we will be given the systems. And if we can't do it a better way, there isn't anybody outside this room that's going to be able to tell us how to do it for our patients better. But it's up to us to demonstrate that, and that's what I want to take part in.
What is Northumbria's commitment to shift away from PBR? What are the benefits and risks to you to do as an organisation? What are the Trust's plans to retain a level of funding to cover overheads, costs and a minimum level of income required to ensure stability as the provider? And what happens financially at the year end?
I'll just say a bit about PBR. I think we've all heard a bit. There are some pitfalls with PBR. There's some benefits with PBR. Take away PBR, we've still got the same problem. We've got too much cost in the system, and we need to get that out. So that's the overriding big picture for me in terms of where we are currently. Our board have been really clear internally that we will move off PBR under the right conditions, and that's, we've held that line externally with NHS England as well, because it's important for Northumberland as a system that we negotiate on that basis, because as Stephen's mentioned and others have mentioned, it's important we get as much transitional support into the system as we can over the next 3 years to make sure that we manage the transition we're going to have to all make together. Because if we go in and take too much cost out in 1 year, we could actually all end up in a worse place. You get redundancy costs, you get other costs. So it's important we manage the transition over a reasonable time frame. In terms of the key headline, we must achieve sustainable balance by year 3. We haven't really talked about how we might then start to distribute any surplus that comes thereafter. So I think that would be a sort of discussion through the development of the ACO. What we are really clear on in terms of the way we financially manage the ACO is that although it'll be part of Northumbria, it will have its own separate set of books, and it will be separately audited, so it'll have its own external audit. So there is external assurance that the money is being kept within the ACO to manage what we need to do within the ACO. But ultimately, Northumbria and other partners, whoever comes in terms of sharing risk, stand behind the overall risk of the ACO. So there is a financial strategy being developed in some detail, which will be part of the final business case. I think one thing and one problem we have currently in the way we're heading is we still have the ACO and we have this purchase. We still have a provider bit of the organisation that we're going to have to maintain, at least for the foreseeable future. I'd like to think we can sort of draw things together in the longer term, so it's one system. And we have, on the provider side, we have control totals that we've all got to achieve. And that's important because we get additional national funding on the back of that.
My experience, particularly within Northumbria, is that clinicians are really, really good at managing finance, because actually the way money is spent within our system is because of the clinical decisions that we take. And what we need to do as clinicians within that system is grasp the metal and really put our thinking caps on and to work out how we can deliver better outcomes in a more efficient way by working together. That is absolutely the key. It's not about financial flows. It's about doing the things that add value to the patient's journey and not doing the things that don't. And it's only clinicians that understand that. But we've never been put together in a set of circumstances where we can see end to end the whole system in a joined up way. And that is our opportunity. But it really does mean that I expect my clinicians who currently work in secondary care, and at the moment we're still in that purchaser-provider world, which is going to have to change. We are talking about how we are going to have to change and think differently in order to deliver this. But every clinician in the system is going to need to do that. And we're really keen to work with people so that we can achieve that.
The biggest debate we have in our organisation every week is about workforce and the pressures on the workforce. And I think, you know, we've got however many people working in Northumberland, 10,000 or whatever the number is. It's how we use the workforce better and more efficiently, as Jeremy's just said, because actually we've got a as big a problem, if not worse, in terms of workforce. I mean, our agency bills nearly doubled in a year. We've got premium costs we're paying out, etc. We need to work much more efficiently and use the workforce a lot better, and actually probably have a much more beneficial working life.
The out-of-hospital model would need primary care to have greater access to diagnostics in the community. Is this going to be delivered, and how do you see this will be delivered?
I worry about the phrase more in it, better targeted, but absolutely what it's going to be about is delivering as close as we can to where the patients live, the resources that we all need. And what we really do need to understand, and I think we do need to achieve, is that actually there's far too much waiting for stuff in the system, and that actually by doing the right thing and bringing the waiting down so that we have all of the right information that the clinicians need to take at that right location, that's how we're going to achieve what we need to achieve. And diagnostics is going to be part of that. But actually care coordination and targeting of those diagnostics will be just as important.
There's two things. One is getting the right diagnostics. What do we really need? What is going to make a big difference? And what's just nice to have and probably doesn't make a big difference, which I think is back to Jeremy's point about targeting. I think the other thing is, and Vanessa's just put this up, is that we've already began talking about a kind of overall clinical strategy. This has been done with some GPs, and we will share this as you know through the primary care leadership group and through the localities, through mental health, through physical health as well. Really trying to actually see what would be a clinical strategy for Northumberland rather than what's a clinical strategy for a practice or what's a clinical strategy for one bit of a trust. And I think actually pulling that together, and that's the kind of first high-level draft of it, starts putting us all in the same place. So actually when we look at diagnostics, we look at what do we need. If we look at any bit of the clinical picture that we've got, we actually try and consider this from all aspects, from the start to the finish, has been mentioned before. So I think that if we look at out of hospital, that needs to be supported and resourced, and actually isn't just a dump of one bit of the system onto another. And actually that's going to be fundamentally important, actually, because actually we can't create stress in the system by just moving things. It's got to be planned and sustainable. And if you look, clinical financial stability is there. It's not, you know, you've got to make sure that everything that we do is thought through to start with.
Primary care is concerned about the quality of services when the trust moves to a block contract effectively under the ACO. How can we ensure appropriate metrics and effective monitoring takes place? I think Bijou from the performance side and Jeremy.
As a trust, because the ACO is housed within the trust, we're still regulated by the CQC in terms of the quality and of the standards of care that we provide. So that will continue. And we're also currently regulated for certain standards of quality of care by NHSI. So again, that will continue. I think we've got a set of metrics that we will set up, and we will want to continue to deliver around patient experience and some core metrics, particularly as we start to change care pathways. The outcomes that will form part of the contract, that in itself, they're all based around a quality measure and quality of services, not just acute services. So there's mental health services in there's primary care services, and that forms a core part of the ACO contract. So those quality measures were measured on in terms of delivery. So that's the basis of which the contract is let.
I think great outcomes is what we're all here to try and deliver. So there's clearly going to be a number of key performance targets that we're going to need to measure across the system. And to be honest, I don't think we've ever managed to map out and measure what quality means right the way across a patient pathway until now. We measure what is measurable, whether it's patient death or various activity things. And this is our opportunity to try and design something that actually is meaningful to us and to patients. That will be based on having a proper information strategy and some discipline about how we go about recording stuff. And that's going to be really key. But I think more important than that is that we actually know what the staff and patient experience is. And I want to emphasise how important staff experience is in delivering good outcomes across the system. So what we need to make sure is that actually, because it's the staff that know the level of care that they're giving. So I think the ability to measure that right the way across the system will give us enormous assurance and also some problems to solve along the way. And I think we're absolutely committed to do that. Data is what is going to, it's what's going to keep us right, and it's what's going to get us travelling in the right direction.
We're short of virtually every discipline, and recruiting from each other's pools of personnel is not going to solve the problem. In the long term, training programmes may be the answer locally, but we do need some sort of fix in the short term. And also, I think this links into what sort of joint working with primary and secondary care, what sort of services will be targeted first, given this difficulty in recruitment?
I think that the way that we've funded medical, nursing and other professionals in terms of future provision has always been cash limited by the way the government allocates resources to universities. So rather controversially, I think it might actually be in the longer term a good thing that they're stopping nurse bursaries. It'll be a massive problem for us in the short term. But effectively, people that are choosing to go into nursing will have to pay fees and the likes in a way that they don't have to at the moment. So on that particular one, we've already decided to establish a nursing academy where we'll grow our own. So in mental health, you tend to get quite a lot of the people that become mental health nurses have actually worked in the mental health sector before they actually qualify. So we're really clear that on the nursing side, in the next 3 to 5 years minimum, until we see the new model settle down, we'll be growing our own from Band 2, Band 3, Band 4. Band 4 nursing staff that are in unqualified roles will then be supported by the organisation to train to be qualified nurses. So I think on the big risk in the next few years, it's the move away from posts being funded by government to enable people to train to be nurses. So as I say, longer term, I think it could be a good thing because it'll take the cap off the numbers. Short term, it'll be a massive problem, and I'm sure it will be for primary care nursing as well. On the medics, mental health has massive problems in learning disabilities, in old age psychiatry. In particular, those two areas are where there are insufficient medics available. They're training even less. And the gap between what's required and what's expected to be available is growing each year. So we've had to, with a bit of a heavy heart, go abroad for international recruits. We've already recruited 18 people, only 3 of whom have gone back to where they were previously practicing. That may not sound like a very good average, but I can tell you that having been involved with recruitment overseas before, that's not bad. So I guess the answer on our side is going to have to be a combination of growing our own and trying to recruit internationally. Having said that, something like an ACO, if we manage to make progress with it and do what Jeremy was describing earlier, might actually make it quite an attractive place to come and work. Because I still don't understand why in our organisation, Northumberland is one of the hardest places to recruit medics. I'd love somebody to explain that to me when it's such a lovely part of the world. We can recruit, and anybody that's from Sunderland, please don't take this as being too offensive. We can recruit more easily into Sunderland than we can into Northumberland. Discuss. So there's big issues for us as an organisation, but I think the bit that I'd finish on is that we have got to find ways of us supporting primary care colleagues differently than expecting you to refer people in and then go through some sort of like being passed from pillar to post. We've got some things happening around that at the moment. Happy to talk to them about them at another occasion because it's probably not best use of the time here. But it's already been mentioned about the IT. We currently now have viewing rights into every GP practice in Newcastle and Gateshead. So we can view, for those patients that are using our services and who've agreed for us to do so, we can view everything that you have about that patient if your practice has signed up to it. And you'll be delighted to hear that stops us from badgering you for the latest physical health monitoring information that you did only a week ago. We're in the process of rolling out out the other way, so that you will have viewing rights into our electronic patient record system, RIO. So I think there are some sort of technical things that will help free up capacity, but also enable us to join up pathways better.
And I just wondered if we're going to be thinking a bit more out of the box. The conventional solution with your recruitment is to try and find more psychiatrists or what elsewhere. Surely this is entirely with the ACO forming. The idea is to be thinking together. Yeah. And why aren't you turning to primary care, to GPs, and thinking about perhaps they are a useful resource to be working together to provide primary mental health care?
And that's why I said we could talk about this for a long time. I mean, that's exactly right. I mean, there's the primary care 5-year forward view, and there's the mental health 5-year forward view. And there's quite a lot of things in there that have got great sort of synergy between them, and that's exactly what we need to be doing. We've established across the Sustainability Transformation Plan and footprint, so Northumberland, Tyne and Wear plus North Durham, a mental health work stream, and we've had our first event, and we had some GP colleagues come along, and we'll be doing lots more. And that's exactly the sort of thing we need to be talking about, is that are there things that you guys can do that with different types of support from our clinicians means that you would feel more comfortable and confident? Are there things that we could make sure that we're providing you with that prevent you from having to keep referring people into the system? So, for example, I'm mentioning Sunderland again. Since we introduced the single point of access and the 24/7 urgent telephone service, we've moved from having GPs telling us that we were absolutely dreadful to giving us universally positive feedback, which we don't understand why, because that's never heard of. I've worked with primary care since 1990, and I'm really struggling with finding anywhere that's had that level of positive feedback, so we must have got something wrong.
I think that Jeremy and Alistair has already articulated that the workforce will be a key part of the clinical strategy going forward, and it'll be a key part of the business case. But just some observations in the short time I've been in the role. I think that we are trialling things in community services and in primary care. For me, the use of pharmacists within the system has been interesting over the last few months, and I know that's been tested out via the Vanguard. I think placing them in front of house and GPs. I think some of you have some of those pharmacists and have started to see the benefit. Having pharmacists actually being part of an MDT and working closely with community matrons and being part of medication reviews has absolutely seen dividends, especially in care homes and nursing homes. But I think for me, the one thing that we haven't articulated, and I'd probably like to be a champion in terms of saying some of this, is our, what I would call, unqualified workforce. It's our largest workforce if we go wider into the independent sector, and it is the workforce that are keeping people in their own homes. So I think as part of the ACO, whilst the social care budget is not part of currently the 400 million, because that's not NHS funding, we've absolutely had 6 years of integrated working and understanding about what a change in workforce can do and what we can do with our unqualified and our independent providers, and I'd like to make sure that that is not missed going forward.
There's a perception that integrating IT doesn't seem a priority for Northumbria at the moment. Is there any likelihood that it will be in place for early and crucial phases of the ACO?
I think we have become, and I have asked the team, particularly as part of the ACO business case, to look at what is possible in terms of integration. But I think we have become a little distracted by a lot of the necessary work that we need to do to reach the levels that John's organisation has in terms of an electronic record. And actually, I think this gives us real opportunities to partner with other organisations that have more expertise and bring people in. But I am going to go on record to say that part of the problem, as I perceive it, is that the barrier around information systems has been between the hospital and the community. And what we need to do is actually to look at the IT system in terms of the inpatient facilities, and then to have a shared system for ambulatory patients. And my vision is that that patients who are on a register, those who have ongoing needs, will be admitted to a care system. And the core of that care system, apart from a group of locality clinicians, will be that whatever those clinicians, when they look at the record, They look at a shared record, so they have all of the info. And if we had that, I think that would be truly transforming to what we can do. And so I'm very committed to working with you, and I've had some conversations with colleagues about how we can do that at scale.
Part of some of the work that we've been doing for the business case is around population analytics, and we've come across quite a stumbling block, and Siobhan has been fighting our corner nationally for us on this in terms of just how we join up our data that we have. So we have a lot of secondary care data, and primary care will have a lot of primary care data. And in the ideal world, you'd want to join that all up, and that's what you would run through the various programmes in terms of risk profiles of people that are likely to come into hospital services. It's the bit about that kind of forward management of those patients so that we get to them before they fall ill. But right now, we can't connect that data together. It's a huge stumbling block because of IG factors. Now, I think, I don't know whether Siobhan's got any further latest hot off the press information, but it's incredible how difficult that, what sounds something very simply should be, that how difficult it's actually been. I think we're hopeful that post ACO we can get to a point where if we are all accepting of sharing our data, we can get to that point much more quickly. But currently, under the current system, that's proving really difficult. So it is the patient record, but actually if you think about the ACO and how it's looking to work in the future, joining that data up is really important because it tells us where the need's going to be coming in the future, not just the here and now, and that will then think about how we manage demand moving forward.
The only thing I was going to say, I'll bring John in a second, but when Jeremy's talking about ambulatory, I mean, the trust is using System 1 as their vehicle, and they've got no plans not to be using System 1, just to spell that out. If people are concerned that you're talking about another system coming in, it's that system that you are looking at, and the more that I think we've seen we've used the Vanguard funding particularly to try and enable practices that wanted to swap to System 1, but that appears to be the currency for ambulatory patients. So it's not we're looking at another system on top, just to spell it out.
There's something called the Great North Care Record that people may or may not have heard about, that there's been work progressing on behind the scenes, and it's made quite a lot of progress in the last year. And that will enable us in the not too distant future to be able to share data between primary care and secondary care, between various different secondary care providers and with local authorities. So that's already happening to a degree. We have a data share that happens every night between ourselves and Northumberland Social Care, for example. So I think you'll probably feel over the next year or two, probably most of it would have happened anyway, but will be particularly powerful for the reasons that Bijou said in the context of the ACO, because we'll all be able to make sure we've got as much up-to-date, real-time, wherever possible information. We have huge benefits to us already from having access to GP information about our individual patients. There's 80,000 people on our books in a given year, and we're now, in the vast majority of our localities, able to view with GP's agreement and with the patient's agreement the detailed information that you hold about the patients, and that then enables us to make sure that A, we're not bothering you again, and B, we're making sure that the information that we're using to inform clinical interventions is as up to date as possible. And I don't think we're that far away from being able to do that with most of the data that we've all got across the system. We're probably talking about 1 or 2 years, not 5 or 10 years, which is where we've all been talking about it for the last. Those of us that are old enough to remember the National Programme for IT and all those billions that were wasted.
I chair a GP federation, and I just wanted to know if, to get us all engaged with the ACO process, what support will you be giving the natural groupings of primary care to enable those groupings to successfully contribute to the ideas that will be required in this ACO?
So in terms of support, I think there's actual resource support in terms of clinical leadership time, managerial support time, but I think it's more than that. I think it's also the skills, embedding them here in Northumberland. So for example, in the GP Forward View this year, there are the top 10 high impact areas that we need to be working on. We want to build a resource. We want to build a culture of quality improvement here in Northumberland. And I think as part of the ACO, we quite like to embed that across the system, but I think primary care is a really good place to start. And in terms of the primary care voice, you've already got a voice as commissioners, and I think the ACO is going to give you an incredible voice as providers as well. And I think we're all very committed in terms of practical, clinical leadership, managerial, but also really good skill bases and expertise to help and support you to really be an equal partner in this.
Just a query about the pathways and the clinical pathways in the future. Will there still be a choice to use patient pathways that involve North and other trusts, even when a service is available through Northumbria? Is there sort of detail on that? I mean, because it's still, as far as we're concerned, very important to have clinical choice in where we refer people.
So I think the simple answer to that is yes, but I think that it will be really important that we will, in Northumbria, offer the best combination of cost, efficiency, patient experience, outcome, and actually embedded public health. So I'm very happy that we live or die on those clinical outcomes, and I would like to think that if we're all working together closely, that when people understood how they had helped co-design the systems that we've got, that they'd want to encourage patients to work with us, but choice will still be there.
One of the issues we have out in the time valley is sort of the distance that a lot of our patients are now having to travel to get to services in North Tyneside and in Wansbeck, and the services are good, but often there are better services available to us in Newcastle, which is also closer and which the patients want to go to. So there's a long way to go before I think a lot of GPs will see your vision actually being there, and I really hope it does work, because that sounds great, and I'm quite excited about the collaboration and working together. But we, as you said, we need a lot more services closer to home in Hexham again, and that can give us a viable alternative to the services in Newcastle.
I can't see there being any issue with moving, particularly the outpatient services. Clearly, Newcastle are still going to run their services in Newcastle, and I think people will view that, and particularly the tertiary services there. And I think there's going to be a difference between the specialisation where people are going for a one-off operation, and the evidence is that people are happy to travel to a centre of excellence for that. And I don't think when we start looking at hospitals actually becoming more specialist around orthopaedics or other bits, that will happen. But the care, which I think you're talking about, Roger, is actually the outpatients, the first contacts and the follow-up needing to be local. And there is also a second issue of, when we've got follow-up, are we just sending people as an ACO? Are they just going through a mill of a yearly follow-up, which makes no actual sense because they're not ill at that moment in time? How much of it is a routine recall? If you think about rheumatology, we give people routine rheumatology outpatients, and they have a flare either 2 weeks before the outpatients or 3 weeks after. We need to move to a world where actually you've got flexibility, that you just pop in to the service that you need when you need it, but you don't get stuck in, going at 3 weeks on Tuesday because actually that was the time that the consultant said, 9 months ago was the right time. And I think we can get that flexibility in as well, and that frees up so that actually we've got a very much more responsive service. And that again is related to how we move the system, both from an efficiency and actually from PBR as well.
If you had co-designed a service that said, I want proper shared decision making, I want to have certain standards that I can expect my patients to get, and I want them to have access afterwards to a care system, why would you encourage them to go elsewhere? And it is about us getting best value for money out of the Northumbria pound, and we need to decide collectively how we do that. And I'm absolutely committed that our services will be better at doing that than anywhere else, and I think that will speak for itself.
Thank you very much to all of our panel tonight. I think this discussion is going to go on. We'll try and work out what forum it will go on in, but thank you very much, everybody. Janet.